I am Laura Frampton. I'm one of the doctors at the Dunedin Clinic for Fertility Associates. And today or tonight, I'm just doing a webinar on a bit of a overview really of fertility screening and planning. So a lot of things that you can be doing at home, things of what you might expect with an appointment, and also I find it quite helpful to give you sort of a wee bit of education on what may be happening and what you can do. So just I thought I'd sort of start with looking at some of the main causes of infertility, or really the reasons behind why some couples may be finding it hard to conceive. And we're talking about heterosexual couples here, but obviously those in a same-sex relationship would need to see us for different reasons, because we would be using donor, or if they're a single person wanting to start a family. But when we're talking about a heterosexual couple who are looking at why they might be not falling pregnant, there's a few reasons that might be behind it. So age is actually the number one reason. So for many different reasons, we're often leaving families until we're older. There's things like starting your career, or it could be just the financial pressure of actually having a family nowadays. It's really a very expensive undertaking. And so just people just generally leaving things a bit later. And I mean, everyone still feels really young, but unfortunately the eggs and sperm don't necessarily feel the same way. Ovulation is another common cause of why people might not be falling pregnant. And so typically if someone is having a regular period every month, they should be releasing an egg every month. But if their cycle is quite different, like varies from month to month, or they might go many months without having a period, it suggests that there may be a problem with eggs being released. And so again, a common cause of why a couple may not fall pregnant. Endometriosis is an interesting one because it's quite a spectrum in terms of disorder. It can be quite difficult to diagnose because some people might have very severe endometriosis but no symptoms, or people might have a lot of symptoms but actually very mild endometriosis. We do know even in the presence of endometriosis, like 60 to 70% of couples are able to conceive without any help. And the more severe the endometriosis, the more difficult it can get. It's quite a difficult one to actually get a more formal diagnosis of nowadays. It's usually mostly a clinical diagnosis, and so suspected symptoms might be treated with, often the pill or the like. And so things like laparoscopy are usually only reserved for people who have got quite significant symptoms and have failed other treatment options. And so laparoscopy is when some surgeon will look inside the tummy and diagnose it that way. But endometriosis in general is where, instead of the uterus shedding its lining as a period, some of that lining can deposit into the pelvis itself. And this is what causes quite a bit of scarring and inflammation and just general annoyance within the pelvis. Which means that things like the ability for an egg to be able to travel down a fallopian tube, or just, general things like that can be affected. Tubal disease. So, again, looking at sort of the whole female anatomy side of things, when an egg is released from the ovary, it has to travel down the fallopian tubes to meet with sperm, and then, all going well, if an egg fertilizes, then it will nestle into the uterus and hopefully take up home there. Sometimes with tubal disease, this can occur because someone has had like a sexually transmitted infection that hasn't necessarily been treated at the time. Things like chlamydia are really, really common in our community, and often it is quite a silent disease, and so there may not be any symptoms associated with it. And so if that has gone many a long time without any treatment, then scarring again can occur and affect those fallopian tubes and the ability for sperm to eggs to travel down them. Other things that can affect the tubes would be if there's been any other sort of surgeries in the pelvis or other infections. And then sometimes there will be the case of a pregnancy occurring in a fallopian tube. And as a result, that fallopian tube has to be removed, as in the case of an ectopic pregnancy. There are male factors, and male factors are probably thought to occur in about a third of cases. It depends on the statistics. Sometimes a third, sometimes a half. It really depends on the studies you look at. But these are where the sperm is not at sort of the levels where we would typically like to see. And so there's two main things we typically look at when it comes to sperm, and that's things like the sperm concentration and also the how many of those sperm are swimming, because there's many, many millions of sperm often, but we only actually want a very small proportion to be doing, actually swimming forward and looking normal, but there sometimes can be abnormalities there. And there's many different reasons for that. It could be because it's something that where sperm is being produced all the time and constantly being turned over. If there had been a cold or a flu or COVID or different things that can affect sperm, and so often we don't get too alarmed by one abnormal test, and so if we saw something abnormal, we'd repeat it and just see if it was a persisting problem and then look at further testing. And then unexplained infertility. So this is, again, depends on what you read, but is thought to probably affect between 10 to 30% of couples. And so this is where all the different tests have been done, and there's no obvious reason for why. On paper, everything looks good. It might be that there's just a borderline sperm count. It might be that there's a borderline egg reserve, or everything actually looks great, and for some reason there's a couple's not conceiving. And this can often be a really difficult group, really challenging for a couple going through unexplained infertility, because it's like, well, what is wrong? If we had an answer, it might make it sometimes a little bit easier. So just going through age in a little bit more detail, if we look at, this is regarding eggs, and so when we think about eggs, the most a woman will actually ever have when they're in their own mum's tummy, and they start to reduce even by the time you're born, and then they slowly decline, and then quite significantly decline up into the age of 30, where by the time you're getting to 40 or 50, there's not as many eggs left. And so they're all declined, and you're down to only about 100 eggs by the time you enter menopause. So the average age of menopause for women is about 51, although sometimes, often depending on maybe what your mum did, you may go through menopause a little earlier or a little later. And so menopause is actually defined as 1 year without a period. And there's a lot of talk about menopause at the moment, and a lot of people often what they're referring to is often that perimenopause period up until when periods completely stop. Now, what that means in terms of fertility, because you're often probably thinking, well, what does that have anything to do with things? We do know that your fertility does drop about 10 years before menopause, and so this is, if you're going to potentially go into menopause a little earlier, it means your window of trying may be a bit smaller. And so the other thing is, like, although your egg reserve or your egg numbers drop with age, the other thing that can change is actually the quality of eggs themselves. And so we know that as you're younger, there's more chromosomally normal eggs, and as you get older, there's more abnormal eggs. And so even though eggs may still be being released each month, there might be a large proportion of them that are abnormal. So it means that even if they're being fertilized, they're not necessarily going to result in a pregnancy, or this is why sometimes there may be a higher risk of miscarriage when you get older as well. And so typically the highest rate of chance of getting pregnant is when you're about 25 or 26, and so that's about 25% each month that you try. So even, you know, your best case scenario, actually the odds are still on the lower side. And this is why it sometimes can take some time, even in best case scenario, to fall pregnant, whereas obviously by the age of 40, you're around about 6% chance each month. And we often do talk all about females, but we do know that men do have an impact on things as well. So men sort of from about the age 35 to 40, often, you know, a woman may find it that it takes about 2 times longer to conceive. And we also know that older men over 40, we're looking at more than 4 times longer to conceive. And there's also the slightly increased risk of miscarriage with older male age as well. So this is probably some of the anatomy, physiology stuff, so apologies if it's a bit boring, but I think it's one of these things that doesn't get taught a lot in school, and I think it's just really helpful to know a little bit about what exactly is going on. But when we talk about why there is a menstrual cycle, there's actually 2 main points to it, because the one point is you want to develop a mature follicle that's going to release an mature egg that hopefully will fertilize, and the second part of it is build a nice endometrial lining, so a nice bed for a potential embryo to just implant into as well. So there's a lot going on, and I'll show you a bit later what all the hormones are doing during this time as well. So a typical cycle often is referred to that 28-day cycle, but a normal regular cycle is anything probably between 21 and 35 days. Obviously, if it's fluctuating 21 days and 35 days next month, that's probably not ideal. But if it's like 21 days every month or 35 days each month, then that would be classified still as a regular cycle where likely you're ovulating each month. So there's often, a lot of talk about the different treatments that can be involved with fertility, but there's also lots of different things you can do at home. And I think this is, where, you can feel empowered yourself to do different things. And, when it has been some time where you've been trying for a child, often tiny little incremental changes can make a difference as well. So going through the menstrual cycle in a bit more detail, we do know that ovulation typically will occur about 14 days before your period starts. And so often they talk about day 14 or day, and then checking ovulation on day 21. Yes, that's all well and good if you've got a 28-day cycle, but as I said, a lot of women won't have a cycle like that. So when we think of someone who had, say, a 30-day cycle, ovulation is typically going to happen about day 16. Now, it's not like the movies when, we're ovulating today, it's really important, now's the time to go. It's most important actually before ovulation occurs. And so we know that sperm survives about 4 or 5 days in the reproductive tract. So it's important to be having intercourse before ovulation occurs. And the actual most fertile time is about 2 days before ovulation. So every other day, often again, if this becomes something where you're trying month after month, it can get really arduous. So you kind of have to do what works for you as a couple. And so if it's every other day, so like 3 times during that month, then that's, all little incremental things. I think from a male perspective, it is important that you probably just don't save up for those 3 days. And so, sperm turnover is really important because dead sperm's not very good for the new developing sperm. So if you can, sort of ejaculating, at least a couple times a week in the rest of the month or other than in that fertile window is quite important as well. Again, when we talk about body changes, often in this fertile time, women will notice a change in things like the cervical mucus, and so it will just be a bit more stringy. So it's essentially allowing sperm to actually get through the cervix, because for the rest of the month, the cervix can be a bit like Fort Knox and doesn't let in sperm for the most part. So other things we're looking at, I mean, a lot of these things are quite, may seem self-explanatory, but often, if you're looking at little incremental things to do, they can be helpful. So when we talk about smoking and alcohol, I mean, we do know that smoking and nicotine in general is not particularly good for our health. So, anything you can do to try and reduce those things is important. Now, alcohol, even for things like sperm health, we know it can have an impact. And, New Zealand is quite a binge drinking culture. So, and we tend to binge and maybe save up to have a binge in the weekend. We know that's particularly detrimental to sperm as well. So where possible, obviously if you can cut things out or stay within recommended limits, that's ideal. But, just if you can make some changes towards the recommended levels, that would be, always make a bit of a difference. Coffee is one of those things that, particularly when pregnant, you still can probably drink some coffee, but maybe no more than, say, 2 drinks a day, and the same type of thing when you're trying to conceive as well. Exercise. For me, exercise, yes, we know it's really good for cardiovascular health. We know that, it's good to be fit, particularly if you're going into a pregnancy. But for me, one of the biggest benefits of exercise is to actually help from a mental health perspective. So, as I've mentioned, or as you may be experiencing, it can be can get quite emotionally challenging when you've been trying for a baby for some time. And so exercise is often a really good way of managing that, just to help clear the head and just sort of have a bit of a reset. And also it's a good way of managing, stress, whether or not it's through your work or actually the process of trying for a child. Because one thing, I mean, we do know that stress probably does have an impact, but I don't find it particularly helpful saying don't stress, because the next thing, you're doing is, you're stressing that you're stressing. And so if you can do things like just go for a walk, go for a bike ride, or maybe even like journal down what you're thinking or do some mindfulness, all those things will make a bit of a difference. If you're working on a farm or with any horticultural sprays or anything like that, just make sure you're using, personal protective equipment. Phthalates are things like found in their perfumes and stuff. So, try and avoid too much fragrance and smelly stuff in the house. Eggs and sperm don't particularly like that. A lot of our plastics are BPA free now, but just sort of make a note of, where you're storing your food and try and make sure it is BPA free. Sleep, again, is part and parcel of that whole stress, and just actually, if we're not getting enough sleep, it can affect our stress hormones such as cortisol. And in terms of supplements, often, again, I often see people who are spending, a small fortune on supplements. So the main one is of folic acid, that you're taking enough folic acid on a daily basis. And so that can vary depending on your age and also your weight. And so if your age is under 40 and your weight is a BMI of under 30, then your dose of folic acid is 0.8 milligrams a day. Whereas if you're 40 and above, or if your weight is a BMI of 30 and above, then the dose is 5 milligrams. There are a few other reasons why you'd have a higher dose, but that would be something you talk to your doctor about. Other supplements that can be helpful are things like making sure you've got enough vitamin D, particularly in winter. And so, we can obviously get that sometimes through things like mushrooms or getting enough sunlight. But if you feel that you're going to be deficient in it, as many, and particularly the lower South Island are, then a supplement can be helpful. Right. So in terms of weight, this is something that sometimes particularly can affect things like your ovulation. And so if you are finding that your cycle is not regular, or has your periods completely stopped, or it's just all over the show, then sometimes just optimizing your weight a bit can help. And so it's changes in your cycle can sometimes be a sign that your body's like, what's going on here? I don't know if it's the best time to be, falling pregnant. We need to sort of optimize things a bit. So there's two sort of scenarios. There's where, your weight is really low, you're sort of in a bit of a starvation phase, and so ovulation stops in those situations. This sometimes can happen with people who also over exercise as well. Likewise, if your weight is quite high, your fertility can actually drop by about 50% in those situations as well. But we know particularly with when your weight's a bit higher, even small incremental changes like 3 to 5 kilos in weight loss can actually improve fertility and resume ovulation. When it comes to diet, if there is a particular diet that may be helpful, we do know the Mediterranean style of eating has the most evidence to support pregnancy. And so we know there's better outcomes even in the IVF lab with a Mediterranean style of eating. And some of these things are the high levels of omega that are seen in this type of diet. And it's actually, probably if you talk to any cardiologist or any sort of a lot of other healthcare professionals, we do know the Mediterranean diet is probably, a way that we should be eating for lots of different reasons. And so that's where we're sort of trying to cut out some of our red meats and maybe swap it for a fish meal or a vegetarian meal, and just making sure we've got lots of nuts and, your good oils like our olive oil and the like. So when you've done all those different things and you're wondering what else, other thing I should probably add about men is just, I do see often sometimes, quite a few people, men doing, say, things like hot yoga or spas or saunas, and that is not very good for the sperm, because the testicles are on the outside of the body to keep things a little bit cooler than body temperature. And so as soon as you start doing those things, it really is going to potentially muck up that sperm. So probably if you're trying for a baby, just stick away from those things as well. So you've tried all these things, or you're wondering when you should come and seek help. So these are typically the guidelines of what GPs would use in terms of when to refer. So if you've been not using any contraception and trying for 12 months, then it's probably a good time to come and have a chat. Likewise, if you're over 35 or 35 and above, it can be good to just check that everything's all right after 6 months of trying. And as I say, a lot of these tests can sometimes be done just through your GP, and if they all look good, then that's all good. But however, it can also be good to see us then as well. You should come and see us sooner, though, if there is an obvious severe male or female factor. So this would be if there's been a couple of semen analysis done in the community which show really low counts or no sperm present, or if they're you're not having periods at all, or you've ended up having surgery and have quite severe endometriosis, or you've had to have a fallopian tube or removed. Those types of reasons would be see us a lot sooner. The other kind of group of people where we would see sort of straight away would be if those who are wishing to start a family where there's a obvious genetic condition, say things like muscular dystrophy or maybe the BRCA gene with breast cancer, and a couple are wanting to have babies but screen those embryos to make sure that they're not transferring an embryo that is affected by the gene. And so this is called PGTM testing, and so that's another sort of subgroup of people we would see. So there are different types of investigations. I'll just run through these. And so these are sometimes done either by us or by your GP, or a combination of both. So the first thing are those first antenatal bloods. And so these are tests that are done when you're often thinking about trying for a baby, or maybe you had just found out you're pregnant and it's the tests that get run. So these types of tests are looking for quite modifiable things in your blood results. So that would be infectious diseases such as hepatitis B, hepatitis C, syphilis, and HIV. It also is looking, screening you for diabetes. It's checking for, that your kidneys are working well. It might just check your full blood count, so make sure that, you're not low in iron, there's no infections present. And so those, and it checks your blood group as well. So in case you were, ever to have an episode of quite significant bleeding and might need blood products, it's always important to know what your blood group is. So that's kind of where your first antenatal bloods, what they are looking at. And then we also look at these reproductive hormones. And so I'll go through them, as I said, about the menstrual cycle in a bit more detail in the next slide. And apologies if that puts you to sleep. But I just, again, find it quite helpful because it can be a little bit confusing what they're all about. We measure your AMH level. Again, I'll have a brief chat about this. And then from a male perspective, you do get some infectious disease screening done, and also we look at the semen analysis. Now, as I said, the semen analysis, the main things we're looking at the sperm count, typically wanting all the values we're looking at are based on the World Health Organization levels they recommend, and so typically would like to see a count of at least 15 million per mil of sperm, and also would like to see a progressive motility, so the number of swimming sperm typically want to be at least 32%. Now, if you've done a couple of those tests and we see that you've got, persisting sort of lower levels or no sperm seen at all, there may be certain further investigations we may do. And that might be looking at your karyotype to actually make, see if you're 46XY, which is the male chromosome karyotype. Sometimes there can be wee switches in some of the chromosomes which can affect sperm. We do, screen that for things like cystic fibrosis and other things, which may sometimes contribute to why there's a low or no sperm seen. Other things we sometimes may do, depending on what we see from these tests, would be a pelvic ultrasound, which we often will do at the time of a consult, just to have a little look at your ovaries and uterus and just see if everything looks okay. If the semen analysis, if there's any real concerns, or if you're not falling pregnant and it's like, let's look into things a bit more closely, we can do semen analyses at our laboratories, which assess for a few extra things, including if there's things like antibodies present, which can sometimes occur if you've had like quite a significant knock to the testes. If there's been any blood exposure to developing sperm, then these antibodies sometimes develop, which affect the ability of the sperm to then get into an egg. So we can test for things like that. So I'm just going to drink. And HSG, now this is where usually it's not something we do at the clinics, but would refer for, is where we would be checking if your fallopian tubes were both open. And, if you had a history of like chlamydia or other sort of possible things that may have resulted in scarring in the pelvis, we might look at doing that. And then finally, on some less common situations, a laparoscopy might be indicated. And that would be if there was possible evidence of some severe endometriosis where, there had been treatments that hadn't worked, or there's been treatments already used for infertility that aren't working, and then there's also quite a lot of significant symptoms. So a laparoscopy can be indicated in those situations. So this is that confusing slide I was talking about, but this is kind of the background for why we measure some of your hormones. So the first time, and this is female hormones, this is a typical menstrual cycle. So at the beginning of your menstrual cycle, all the hormones are really low. And so we measure your day 2 to day 4 bloods because we want to see everything just nice and low and nothing really happening as such. And so we can tell that they're at baseline because the estrogen is low. Now, if for some reason we do these tests and your estrogen is really low, but we see one of these other hormones, which gets produced by, the pituitary in your brain, is quite high, we go, what's going on here? And sometimes it might, make us wonder, are you potentially in, perimenopause or something like that? Is your egg reserve really low, and actually your chances of now becoming pregnant quite low? So this is why we measure some of those tests at the beginning of your cycle, just to check that. The other thing we can do is that once an egg is released, which is sort of in your mid-cycle, about 7 days later, we can measure a progesterone level, because once the egg gets released from a follicle, the leftover follicle starts producing this progesterone, which helps keep the bed of the uterus all nice and, stable for an embryo. And so checking progesterone, if it's elevated, it shows that, yes, an egg was released. So in a nutshell, that's what those hormones are looking at. AMH, this is one of these terms that we talk about quite a lot in fertility, and you may not have heard about it before, and you might not hear about it outside of fertility. So AMH stands for anti-Müllerian hormone. I've also heard of it being called anxiety-making hormone, because it can, people can get quite worried about what their AMH levels are. So essentially AMH is it's produced by the follicles in the ovaries. So the follicles are what essentially the eggs are released from. So it's thought to reflect the remaining egg supply. So it gives us an idea of your ovarian reserve. So we do know, if we look at this graph over here, that it does decrease with age. And we do know that if, you have something like polycystic ovarian syndrome, so you've got lots of small follicles, you're going to have typically a higher AMH than, women without polycystic ovarian syndrome. So I think the important thing is irrespective of someone's AMH, it does not reflect at all the quality of the eggs that are being released or someone's actual chance of conceiving naturally. What it helps us, tells us about as, fertility doctors, is that we can tell by your AMH typically how you may respond if you ever do IVF. The other thing it can sometimes tell us is if, it's in the green zone or this amber zone, then, you possibly will follow the natural trajectory and go through menopause around that age 51. However, if your egg reserve is really low, then you may go into menopause a little bit earlier. And so it means that, that window for trying is a bit shorter, as I sort of alluded to earlier on. So in terms of what happens when you see us, is, you can either be referred by your doctor, or you can refer yourself privately. But we would take a bit of a history from both you and both of you. Things we're kind of particularly interested in, obviously any surgeries you might have had in your pelvis, infections, possibly if there's been a family history of any fertility problems, if there is any history of trauma to the testes or surgeries or anything like that. We go over all the investigations you've done, so those ones I've already discussed, and then may discuss some of these further investigations depending on what your history shows and what may be necessary. And then we can come up with a bit of a treatment plan. So in terms of fertility treatments, often it might be just that more time is needed. And for many couples, it might just be that, you just, a few more months, or it might be all that's needed, or it might be that even another year or two, you'll have no problems in conceiving and it's just taking a little bit longer. But occasionally, well, there will be a group of couples where fertility treatments may be beneficial, or maybe the way that they need to go to actually conceive. So this just briefly runs over those treatments. So one of them is ovulation induction. So this is where, particularly for women who are not having a regular cycle, so, their period's completely stopped, or they're having it very irregularly, it's all over the show, we can use either clomiphene or letrozole, or the common drugs we use, which helps to encourage a couple of follicles to grow, develop mature eggs that then, as a couple you can target. And so when I mean target, we can look at the size of the follicles. We can go, we actually think that you're going to ovulate from them in a few days. And so, your next 5 days is the most optimal time to be having intercourse. And so we tend to monitor that in the first month, and then if it works and your cycle regulates and you have this window of that you're able to target in terms of intercourse, then you can kind of often do that on a monthly basis without, our input, because we've got a template from that. The next step up is something called intrauterine insemination. So this, we typically use the ovulation induction drugs in as well, but IUI is often sometimes used by couples who may have unexplained infertility, because, as I said, sometimes it might be that the cervix is, preventing sperm to getting into the uterus. Sometimes it's the sperm is not really swimming as well as it could through the cervix. And so if we can bypass it, the cervix, and actually put the best of the sperm directly into the uterus, then it can increase those chances of conceiving. And sometimes the statistics suggest that it can be up to about twice the chance of success in a month if there is an obvious infertility in that couple. And then finally, IVF. So IVF, some couples will be eligible for IVF. There's quite a lot of stringent criteria to get on a public waitlist for IVF. If we can't find any real obvious reason for why someone isn't conceiving, a couple's not conceiving, then it's 5 years of trying before they can be put on a waitlist for treatment. Otherwise, if there'll be different points, a bit like even if, you're going on a wait list for a hip replacement, there's different points allocated to different things. But the point of IVF is to encourage your ovaries to develop lots of follicles, and that will be quite dependent on your AMH level. And once we have some big size follicles, so hopefully some good mature eggs, we go and drain the follicular fluid, collect eggs, and then once we have the eggs, we either do IVF, which is letting egg and sperm hang out and they fertilize by themselves. If there's sperm issues, so sometimes this can be a particularly good choice if someone has got a very low sperm count, then the very best looking sperm is directly injected into each egg. And then we find out how they fertilize the next day. And then 5 days later, we might have some embryos that we can transfer. IVF has got the best success rate when it comes to fertility treatments, but like all fertility treatments, it's not like a magic bullet. So often best case scenario with, younger age, other, good AMH levels, you're looking around a 45% chance of a successful a live birth with a cycle of IVF. So I've come to the end quite quickly, but I hope in a nutshell that's sort of a bit of an overview of what you can do, what kind of investigations we typically do, what type of treatments we sometimes talk about, what you can do as well. But in many ways, it's one of these things that, if you do have any particular questions or do want to reach out, then we have sort of free nurse consults as well. So they can talk you through different things similar to what I've talked about, and always arrange appointments if, it seems that'd be worthwhile. Or, even have a started conversation with your doctor. But, I think it's one of these things, if it's on your mind and if you're not sure, then sometimes just even getting a few tests done to just, have that reassurance that, you're both doing the right thing to start off with, and then go from there. So I'm happy to take any questions if you've got any. So I'll be around for sort of another few minutes. Otherwise, obviously you can get in touch with one of the nurses if you have questions that have come about as well. Let's see here. So I've just had a question here about, does polycystic ovarian syndrome impact fertility? And the answer is that yes, it can. There's different criteria for a diagnosis of polycystic ovarian syndrome. And you typically need to meet 2 of 3 things, but one of the criteria can be the absence of a regular cycle. So you're not ovulating each month. And so if you're not ovulating, it does affect your fertility. And that's where often things like that ovulation induction can be a really simple thing sometimes to help result or resume ovulation again, and then as a result improve your chances of conceiving. So sometimes it can feel like it's you're a hopeless situation if you've got PCOS, but it's not, because there's actually pretty good treatment methods for it. In terms of, do you get a treatment plan on your first appointment? Yeah, typically you will. And sometimes that treatment plan will be like, actually everything looks really good. It seems completely reasonable that we give things another 3 to 6 months and then make a plan. But often it will be that, let's talk about, these are different treatment options. We don't necessarily need to explore them here, but these might be the steps that we could look at in the future. And so, that would be dependent on that individual couple. As I said, if someone didn't have a regular cycle, we might sort of start a plan straight away. But often, you might not want to make that decision straight away. So we might, go away, have a wee think, and then one of our nurses at the individual clinics will contact you, or you can contact us to decide what you want to do. IVF cost is quite variable. It really depends on the dose of drugs that will be used. It depends on if ICSI is required, so if there's sperm issues and ICSI is required. You're looking at probably somewhere between $13,000 and $20,000-ish. The information is on the Fertility Associates website. Often depending on the clinic, privately you can get underway with that within usually a few months. But again, it will be dependent on the clinic that you see. A question about, can you get your doctor to do an AMH test? And yes, you can. It's not a funded test in all parts of the country, which is slightly crazy, and is something that, is a constant source of conversation throughout the country to try and get it to be funded, particularly up north. But yes, you can get your AMH checked. It's just about, once you have that level, if your doctor feels that they feel comfortable interpreting that result. But, you can obviously have a chat to us if you need to, but your GP should be able to do that for you. In terms of differences between a GP referring and self-referring, yes, so if you meet the criteria for you have to meet certain criteria to get a GP funded appointment. So if you are, say, under 40, your BMI is 35 or below, and you are non-smoker, non-vapor, and you've been trying for about a year, or 36 months if you're 35 and above, you will get a funded, or there's an obvious issue, you will get a funded appointment, so the appointment will be free. If you don't fall into those category, or if you want to be seen straight away, then you can still be referred by your doctor, but that would be in a private setting. Alternatively, if you just want to bypass your doctor, you can be seen privately, but the appointment typically wouldn't be funded straight away. When you see us, if we feel that you would be eligible to be placed on a wait list sort of straight away for funded treatment, we will do that for you. We won't, just because you've been seen privately, sort of say that, you know, public treatment's off the table from that perspective either. Wait times for initial appointments, again, seems to be it depends on where in the country you live. Obviously, our big health system was, you know, supposed to remove that postcode lottery, but some places you'll get appointment quite quickly, other places where there will be maybe a couple of month wait. And again, it will depend on whether or not you're being seen privately or publicly. Fibroids and infertility. So again, it really kind of depends on the fibroids. We do know that there's 3 different types of fibroids. There's ones that are on the outside the uterus, there's ones that are in the muscle layer of the uterus, and there are ones that button to the inner part of the uterus. Now, it's those ones there that can potentially affect embryos from implanting. But you've got to often sometimes weigh up about the treatment of them if it's going to have a detrimental effect. So typically some of those other fibroids would not be treated, and we would just leave them well alone if we know they're there. However, if there are ones that are actually potentially going to affect embryo from actually implanting, then often they may be ones that would be worthwhile removing. Myo-inositol and recommendations regarding that. So myo-inositol, it's a supplement, and the main thing that it may be helpful for can be things like polycystic ovarian syndrome or cycles which are quite irregular. So if you fall into that group where you've got an irregular cycle and you are wanting to try something, then myo-inositol can possibly help. And so the recommended dose is typically 2 grams twice a day. Often in that group with PCOS as well, metformin can be used as well. So the new guidelines are suggesting metformin even for weights where your BMI is 25 and above, because that again can help regulate your cycle as well. If you have an appointment coming up but find out you're pregnant and have a history of miscarriages, would you still go to the appointment? It's a difficult one. I suppose you'd probably get different answers depending on which doctor you talk to. We do know that miscarriage is unfortunately really common, and even if you've had a number of miscarriages before, there's hopefully a good chance that an ongoing pregnancy will be okay. Sometimes there might be different things. We might suggest an early pregnancy if you have had a miscarriage, and there's a few different types of tests that could be done. So it may be worthwhile still having a catch up, or make actually, even if you've got a good relationship with your GP who you feel might have a good knowledge of these things, they can sometimes even reach out and ask if we've got any advice as well. AMH cutoff point for IVF. Technically, it is around 5, although we do still try IVF with AMHs under 5. I think it's just a conversation we often have with, patients going through it with low AMHs, because we know we might not, develop many follicles, and so there might not be many eggs that we collect, and so as a result, the outcomes are going to be potentially less successful. But it's just a conversation that we'd have with you. The thing that's probably more of a concern is if your FSH hormone was really high, because we know that your chance of responding is going to be really low. But that would be an individual conversation, depending on those levels and the big picture, really. Usual wait times, as I say, it will vary. It can be 2 months, 4 months, sometimes longer if it's a funded appointment. If you've had all the tests done and you're still waiting on your appointment, in most cases, the clinic's quite happy for you to have the results. The only thing is sometimes if you get the results and they're a bit like, what does this mean? That can sometimes be a bit scary. So that's where sometimes the consultation is helpful, to be able to talk through what they mean and put them in context. But if you do want those results, I mean, they are your test results, so you can get them. Just another thing about IVF public funding, and that, yes, in some cases IVF is publicly funded, but you have to be scored for it and have to meet different criteria to get on a wait list for treatment. But that's something that will be done at a consultation. And again, starting treatment will vary depending on clinics you're at, but often you would hope that once you're seen, most treatments can be done within, 2 to 4 months. In terms, this is just regarding changes in periods, but one thing just to be, when we talk about day 1 of your cycle, day 1 is when you wake up with bright red bleeding in the morning. So if you start bleeding at 8 o'clock at night or 2 o'clock in the afternoon, that's not your day 1. Your day 1's the next day. And so that's what that means. And again, if your cycle starts to fluctuate a little bit, just remember that ovulation is 14 days before your period starts, not 14 days after. So it might be that your ovulation date goes from day 14 to day 10, if that makes sense. And fine, I'll just do one more question. A BMI cutoff. So for publicly funded treatment, if you are in the process of going to be scored for publicly funded treatment, BMI cutoff, female have to be BMI of 32 or below. There is a lot of chat that we feel that this should be increased, but for the foreseeable future, that will be at a government level or Ministry of Health level. That won't be changing at the moment, but that's what that has to be. For any private treatment, some of it will be dependent on doctors, but for the most part, the general consensus is that treatment shouldn't really be done on people who have a BMI of over 40 or much over 40. And the reason for that is not necessarily the treatments themselves being dangerous, but it's more so in pregnancy itself, all the complications that are increased, such as diabetes and high blood pressure, and actually higher incidences of, needing, cesarean sections with general anesthetic and all that type of thing. So typically our obstetric colleagues get, we work with them to make things as safe as possible. But yeah, there'll be some individual variation. But if you can get your BMI closer to 40, that will be probably most optimal. And yes, no, BMI doesn't actually include men, which it should probably. But again, it's the way the things are. So yeah. Anyway, I hope in general that was helpful, and you got something out of it. But obviously there's those free consults, nurse consults, if you want to explore things a little bit further. But often, hopefully feel empowered that there's a few things you can do yourselves, and when you should sort of reach out and maybe just get a few tests done for at least peace of mind, if not to start the journey a bit further. Awesome. Thanks.